All right, welcome to session 4. And I'm Mike Demeure. And so everybody, thank you. First paper to be discussed is by Dr. Ahmad and his colleagues at Stanford University on angioembolization for splenic injury and how necessary is it. So thank you.
Good morning. Is this screen come up here? Just a second here, technical difficulties.
Margie, this monitor is not showing pictures. Sorry about that. This, the monitor here is not showing the slides. Okay, moved back a little bit. So I suspect, is there a wire loose? Or something's
Oh,
on
there you go.
now.
Something's
You got it.
happening.
It's on now. Thank you.
All right, wonderful.
All
Thank you for your
right.
patience.
Dramatically.
Good afternoon. I'm Usman Ahmad. I'm a postdoctoral research fellow at Stanford. My sponsor is David Spain. Today, we'll be talking about angioembolization for splenic injuries. Does it help? And so we'll be looking at a retrospective review that's compared to the National Trauma Data Bank. I'd like to thank the Western Surgical Association for accepting our paper here for presentation. We have no disclosures. I'd like to thank all the authors and the team listed and unlisted here that have helped us in data acquisition, analysis, and writing the manuscript. Today, we're going to talk about blunt splenic injury. So there's two types of blunt splenic injury, unstable and stable. Unstable blunt and splenic injury is typically managed with immediate surgery. Stable blunt splenic injury can be managed in three ways: expectant or non-operative management, splenic angioembolization, and surgery. Current controversies in management of stable blunt splenic injury include who should really undergo immediate embolization versus non-operative management or surgery? And does routine prophylactic embolization improve the success of your management? At our training program, we observed two practices. We infrequently use angioembolization for stable injuries. And we observed that there was a low rate of failure of our management practice, meaning that patients didn't have to have an additional intervention after initial management. So our hypothesis before looking back at our database was that performing SAE less frequently is not associated with higher rates of failure of non-operative management. So our study design looked at two data sources. So we have two level 1 trauma centers within our training program. We looked at 10 years of data. We also compared that to a cohort representative of the same patients in the National Trauma Data Bank for 1 year in 2018. Our inclusion criteria included any patients with a diagnosis code of blunt splenic injury, and we had various exclusion criteria, including age, stability, grade of spleen injury, patients that were deceased in the emergency room, and a few other things, including penetrating injury and missing data. Unstable patients were defined as systolic blood pressure less than 90 on initial admission, or when that was unavailable, tachycardia or bradycardia, or we excluded all patients that didn't have initial vital signs. Our data analysis included demographics, injury data, vital signs, the interventions we talked about, and outcomes. And procedures were stratified by initial strategy during the first 24 hours, meaning that when the patient walked in the door or into the trauma bay, whatever the initial management was in the first 24 hours were how they were initially stratified. And we defined failure as the need for an additional intervention after that first 24-hour period. We used both univariate and multivariate analysis, and our multivariate analysis included an analysis of initial management strategy, what were predictors of SAE or surgery, and what were predictors of failure of non-operative management. This is our cohort here. So we started off with 663 patients with blunt splenic injury over a 10-year period. We excluded patients for a variety of reasons here, including grade 1 and 2 injuries. So it was only 3 to 5 in terms of the grade of the injury. And we ended up with 233 patients that were stratified. Similarly, we did the same with the National Trauma Data Bank, excluded a number of patients, ended up with more than 7,000, and then they were stratified into groups by initial management in the first 24 hours. If you have a phone, you can kind of scan this QR code and take a look at our table 1. There were no differences in the age of the patients, the injury grade, which is important, and some initial vital signs like heart rate and the initial management with blood products at 4 hours. However, we did find differences in gender. We generally had more males in our database compared to the National Trauma Data Bank. Due to our location in the Bay Area, we had more Asians as far as race, more Hispanics, and the mechanism of injury was different. We had more motorcyclists than bicyclists in our mechanism of injury, as well as we had more complex injuries. We had a higher ISS score, and we did see some effect of a higher rate of blood transfusion at 24 hours. When we started to look at outcomes, there weren't any differences in mortality or length of stay. However, there was a slight difference, it looks like, in the ICU length of stay. And when we compared initial management strategy, we found that we actually tended to manage patients more non-operatively more often, 69% versus 60%. We also had a lower rate of angioembolization overall, 7.3 versus 18%. When we looked at failure or the need for re-intervention, after that first 24-hour period, you can see in our non-operative management group, our rate of re-intervention was low, 1.3% versus the data bank, which was 8.8%. And similarly, for any patient that received any intervention up front, we didn't need any re-intervention in this cohort compared to the data bank, which was 3.7%. There's a few interesting notes. Now we are stratifying the data by the grade of injury here. So I just kind of drew a line across here to make it easy to see. And so I want to direct you kind of to the top left and where it says Roman numeral 5. So that's grade 5 injuries. So I kind of drew a line at the total rate of any intervention for grade 5. And you can see we intervened at a higher rate at grade 5 injuries compared to the right side. When you look at the number Roman numeral 5, so about 80% versus about 72% overall in grade 5. And you can see that there. We also had a higher rate of non-operative management, those gray blocks, compared to the grade 3 and 4 injuries on the right side. So we intervene more in a certain class, but also intervene less in lower grade injuries. And you can see here they had a higher rate of angioembolization compared to our group here. And when you look at the bottom of the chart here, you can see these are the rates of failure. And when you stratify the failure rates or the need for re-intervention, we had a very low failure rate on the bottom left there. And when you look on the bottom right, you can see for the non-operative and angioembolization groups, their rate of failure ranges from 5% to 16%. So you can see that there's some patients that might need additional intervention, especially in that grade 5 injury group. We did a logistic regression to control for confounding variables and predictors of angioembolization. So the question was, who's more prone to get angioembolization up front in both groups with the variable controlling for the data bank. And so we can see that the data bank was more, significantly more likely to embolize their patients compared to us. There were a few other things that we found. All the variables here are significant, but for brevity, we'll just highlight some of the salient features that were the most significant. Grade 4 injuries were more likely to get embolized versus grade 3. And then there was some effect on mortality, which we did not explore further on this first analysis. This is really looking at predictors of surgery. So the only non-significant variable here is the difference between cohorts. So there's no difference in initial surgical management overall when, on a confounding variable, multivariable analysis between our cohorts. However, overall, patients were much less likely to get surgery if they had a grade 3 or 4 injury, or reciprocally, that means if you had a grade 5 injury, you're more likely to get surgery. This is looking at what was associated with failure of non-operative management. And you can see again, the National Trauma Data Bank had a much higher rate of failure for their non-operative management compared to our group, as well as grade 3 injuries of the spleen were less associated with any type of failure with non-operative management. And another salient feature was comorbidities, but due to some complexity, it may not be adequate to analyze it in that way. So overall, there was no difference in the rate of initial surgical management when grade of injury was taken into account on multivariable analysis. And these are what the numbers look like. So 24 versus 22%, and you can see the odds ratio is non-significant. Initial SAE was performed about 2.5 times more often in the data bank group compared to our group. And you can see here, our group is 7% versus 18%, and the odds ratio is about 2.59. And despite higher use of SAE or angioembolization in the data bank group, there was still a higher rate of failure of non-operative management. So 1.3 in our group versus 8.8% with an odds ratio of 12.6. There's some limitations. There's a possibility there's other confounding variables that were unmeasured between the cohorts. The patients were stable based on our exclusion criteria, but other injuries were present and may have affected intervention strategy. Coagulopathy was measured indirectly with transfusion, which may not be clinically accurate. There may have been a loss of patients to follow-up, which may decrease measurement rates of failure beyond the time of discharge. And, practice-based thresholds of management may differ. Someone may take someone to surgery and angioembolization at a higher rate than someone else at a different practice. And so that may artificially increase your rates of failure. And so that's hard to control for. So major conclusions, initial strategy of non-operative management is safe for hemodynamically stable patients with grade 3 injuries. Earlier intervention may be warranted for high-grade injuries, even in stable patients. And management with selective SAE may not affect overall failure rates or mortality. Thank you.
This very nicely presented paper will be discussed by Dr. Doug Schur from WashU. Thank you.
Thank you. I want to like to thank the Western Surgical and the program committee for the opportunity to review this paper and the authors for sending it in a very timely fashion, well-written manuscript. I always like to review papers that confirm my bias. In this case, my bias, unfortunately, is that some blunt trauma patients who may or may not be a little bit unstable would probably benefit from embolization sometimes, maybe if they have a blush too. So knowing that bias getting in there, I seriously, the authors have made another good attempt at trying to better define who needs and or benefits from splenic artery embolization by comparing the excellent data they have to the National Trauma Data Bank. They studied their blunt spleen injuries over 10 years and compared that to a single year of 2018 in the Trauma Data Bank. They initially found surgical interventions were similar in the groups, but their center used embolization much less. And furthermore, these 2 level 1 trauma centers had many fewer interventions after the initial treatment plan. Regression and multivariate analysis showed that embolization was associated with lower comorbidities, decreased length of stay, and a lower mortality. Those that got surgery were interestingly less insured, but also understandably were older with increased length of stay. Importantly, the authors in the study do recognize that the patient populations between these 2 cohorts were not the same. In summary, they conclude that compared to national data, they performed a comparable rate of surgery, but significantly less embolizations with less additional interventions. But in appropriate patients, embolization appears to be life-saving. The appropriate patients is the crux of the issue and brings me to several questions. Is it fair to compare one single year of 2018 NTDB to 10 years of your practice at your institution? Have practices changed over time in either the management of resuscitation or coagulopathy control that might have affected the results in either of these 2 cohorts? Also, did you assess the NTDB level of trauma center when you looked at that data? There are many level 2 trauma centers that do not have the ICU or resident workforce to perhaps watch or provide non-operative management for a longer period of time. As such, the trigger to do embolization may be earlier and may affect the results. Were you able to look how many of these NTD patients were at level 1 centers that were lower than a level 1 center? And finally, when we speak about spleen grades of injury, can we really group them all together anymore? In your study, any intervention rates for grade 3 was 24% in the Trauma Data Bank and 14% for your patients. And then you go to grade 4 and the rates are 58 and 40 and 70, 82, much higher rates of intervention. In both groups, grade 3 made up well over 50% of your study population. Are you just diluting the intervention effects for 4s and 5s by including the level 3s? We individualize cancer treatment, we've seen that here today, by genomics. Should we be more particular when we look at spleen treatment algorithms to include specific grade recommendations and also to include the presence or absence of a blush or active bleeding? Thank you again for the opportunity to review this well-written paper.
Thank you. And the closing discussion would be by Dr. Spain. Thank you. Oh, we have a question. I'm sorry. Apologize.
Yeah, Jerkovich, Sacramento. Beautifully presented. Really nice job of running through the data. I have 2 things that I'd like to comment on. One is the follow-up question. That is grading. We don't really we don't really know how accurate we are with grading, right? We read a grading report from a radiology report or from a clinical record, and there's really no a testing of how accurate we are with grading. So I'd like you a little bit to comment on the issue of grading, particularly blush. I think that's an important one. The second one, I was a little confused about non-operative management failure. Is that failure of anyone who is intentionally managed non-operatively, or is that a failure of splenic embolization that then needed an operative treatment? If you could be a little bit more specific about non-operative management failure, does that include only embolized people, or is that the whole group? Nicely presented. Thanks.
Hi, Lee Neumeier from Jacksonville, Florida. And I had the same question about the standardization of the reads. I don't think they're standardized. They just pull whatever into the NTBD that came from the radiology. And I think we have a real problem with that. Then my other question has to do with, in almost every situation, if there's more surgeons, there's more procedures. So I'm wondering how you're able to keep your splenic embolization rate so low. We have really gung-ho interventional radiologists in Jacksonville. And so they're happy to come in. They'll embolize anything most days, sometimes in the night too. So what's the availability of your IR people at both your hospitals, and is that impacting your lower rates? Thank you.
Dr. Diaz.
Hi, Jose Diaz, University of Maryland, shock trauma. I'm just going to add more weight to the first comment about staging. That's all I'm going to say about that. The other question I have is one of the things that we routinely do is serial CT scans on certain patient populations, those that were initially grade 3 that you're going to watch. Do you have any of that in your own institutional? Is there any way to get any of that data out of the NTDB? Other question is specifically about preemptive embolization on certain patient populations, not necessarily those that are unstable, but those that have a blush or a pseudoaneurysm on an initial CT scan. Is that part of the practice? Could you tease that out of NTTB? Is there any additional data? And then third question is, as mentioned earlier, who is a failure and goes straight to surgery, who is stable? Is it the large capsular injury, or is it still something else? Is it the something particular with a pseudoaneurysm, maybe more than 1.5 to 2 centimeters in diameter? Thank you very much. I enjoy the presentation.
Yeah. And Dr. Berry.
Hi, Sharice Berry, New York. Excellent presentation. Our guidelines for our institution and at Bellevue is to embolize all grade 4 and grade 5, just based on previous data. I just wanted you to clarify for your angioembolization, is it proximal always, or is it distal, or was there a combination? And did that affect your outcomes at all? Just the type of embolization or the location of your embolization.
And if I might add one other question, comment on contraindications, in other words, associated injuries or things that would prompt you to maybe not embolize, but go ahead. I mean, if there's other injuries and things. So add that in, Dr. Spain. Thank you.
Great, thanks. Yeah, well, thanks, Dr. Ahmed. May you present an interesting paper, so you got a lot of questions. So first of all, Dr. Sure, we chose 2018 NTDB because it was the most recent available data at the time, and it should reflect the most current practice. I think if anything, it might sort of prejudice against ours, or what was sort of 8 to 10 years earlier. I do think resuscitation practices have changed, but I think it was just the most recent year we could get. As far as level 2 trauma centers, technically they should be able to deliver all the exact same care as a level 1 trauma center. They just don't have the teaching and research requirements. So theoretically, they should be able to deliver the same care. We can go back and look at if there's a difference between 1s and 2s. And just for completeness sake, level 1 trauma centers are about 57% of the hospitals in the NTDB. Level 2s are about 34%. So together they account for 91% of the hospitals in the NTDB. And then finally, we do agree that for all blunt splenic injuries, this is one place where we should be splitters, not lumpers. 3s are different from 4s, are different from 5s. Dr. Jerkovich and Dr. Neumeier both asked about the accuracy of the radiology read. That's a issue, right? We sort of take it at face value that they did it correctly. And we have finally gotten our radiologist to include the grade of when they have CT scan of like liver and spleen injuries. We've done some quality control and they seem to be pretty accurate, but I don't know that everybody in the NTDB does that. The question of what's a failure is a good question, Jerry. we all have different thresholds. So we did separately look at the failure of patients who both underwent non-operative intervention and patients who had upfront angio and embolization. How many of those people required a subsequent intervention? And for our patients, it was almost zero for either non-operative management or angio and embolization, 2%. Interestingly, in the NTDB for patients who had angio and embolization, for grade 4s and 5s, somewhere between 8 to 14% of those people needed another intervention. So even after that, Dr. Neumeier, maybe our interventional radiologists aren't quite so available. We've had some blush, but our tolerance for not intervening on a patient with a blush has sort of increased, right? So we've had episodes where we have a CT scan, there's a blush, I want IR to come in, it's 2 a.m, like, maybe not. And then 24 hours goes by and the patient looks fine. And their hemoglobin hasn't changed and they didn't get angio and embolization and, their hemodynamics are fine. Their H&H hasn't changed. And so our tolerance for some of these smaller blushes has grown over the years. And somebody did ask about late. I think it was Dr. Diaz asked about late. So for all the 3, 4s, and 5s that we manage non-operatively, we do get a CT angio before they go home. And if they do have a pseudoaneurysm or a blush at that time, we do angio and embolize them before they go home. Somebody asked, Dr. Diaz also asked about straight to the OR. Some of these patients may have been, we saw something on the CT scan, made us nervous. We went to the OR. Some of these patients may have had other injuries that indicated going to the OR. So they had a ruptured diaphragm and a grade 3 splenic injury. So you're taking them to the OR for the diaphragm and you're, doing a splenorophy or splenectomy because of the injury. So it's kind of hard to ferret that out of the NTDB data. Dr. Berry asked about, do we do proximal or distal embolizations? Most of them are proximal, at least in our setup. You can't really tell that in the NTDB. The paper, the thing that really prompted this was there was a paper that suggested that all grade 3, 4s, and 5s that are managed non-operatively should have an angio and embolization. And if you do an angio, then you're going to do an embolization. That's what happens, right? And so, when we looked at our data, like we only use angio and embolization like 7% of patients, and our failure rates in the single digits. So I'm not sure that this routine angio and embolization for all grade 3s and 4s is necessary. There's some patients that clearly benefit. Question is trying to ferret those out of the database. Thank you.
Okay, the next paper is from the University of Arizona, and it's from Dr. Joseph and colleagues, and presenting will be Dr. Belkawakse.
Good morning. I'd like to thank WSA for providing me the opportunity to present our work today. I have no disclosures. Suicide represents the 10th leading cause of death in the United States. And between the years 2000 and 2016, the rate of suicide has increased by nearly 30%, averaging by a 2% increase every year. Suicide attempts are the single strongest predictor of completed suicide. And following a failed suicide attempt, it has been estimated that the 12-month rate of repeated suicide is 16%. Thus, suicide attempts offer a valuable opportunity to intervene in order to prevent future suicide. And psychiatric inpatient hospitalization is nearly almost always indicated for patients with a recent suicide attempt. This recently published paper by the group in Yale looked at the national trends of mental health care among survivors of suicide attempt. And they found that only 40% of patients who survived an attempt received mental health services in the year of their attempt. And more than 1/3 of patients who believed that they needed any help, any mental health services, did not receive them. Similarly, this systematic review highlights that a lot of patients who need mental health services do not receive them, and they found that this was even more evident in patients of minority populations, younger age, and male gender. However, the previously mentioned papers and most of the existing literature focuses on mental health services prior to the suicide attempt. But little is known about receiving mental health services following the attempt, and particularly in trauma centers. Thus, we aim to describe the rates of receiving mental health services during hospitalization and on discharge following attempted suicide in US trauma centers. We also aim to identify factors associated with receiving mental health services. We hypothesize that significant disparities exist in the nationwide practices of mental health services interventions in survivors of violent suicide attempts. This was a 3-year retrospective analysis of the ACS TQIP database, which is the most comprehensive trauma database maintained by the American College of Surgeons. TQIP tracks information related to suicide attempts and receiving mental health services. We included all adult trauma patients who presented following a suicide attempt and survived their index hospitalization. We excluded those who were ED disposed, those who had superficial abrasions, as these may represent a non-suicidal self-harm, and those who were transferred to a non-psychiatric care facility. Our outcome measures were receiving mental health services among those who presented with suicide attempts and survived their index admission. We defined mental health services as receiving inpatient psychiatric consultation, admission to a psychiatric distinct unit of the hospital during the index admission, or discharge to a psychiatric facility following the index admission. TQIP defines psychiatric comorbidity as pre-injury depressive, bipolar, schizophrenic, post-traumatic stress disorder, or major personality disorder. We performed the following statistical analyses. In our multivariate regression looking at the independent predictors of receiving mental health services, we adjusted for demographics, including age, gender, race, ethnicity, insurance status. We also adjusted for comorbidities such as cancer, alcohol use disorder, substance use disorder, and major psychiatric comorbidities. We also adjusted for admission, illicit drug and alcohol, drug screens, admission vitals, injury parameters, and ACS trauma center verification level. Among all patients in TQIP 17 to 19, we identified nearly 40,000 patients who presented following a suicide attempt. After excluding patients who died in the index admission, had ED dispo, those with superficial abrasions, and those transferred to another care facilities, we had 18,701 patients. Of those, 56% received mental health services and 44% did not. Now let's take a closer look at the included cohort. Most patients were young adults, insured, white, male, and non-Hispanic. When comparing those who received mental health services to those who did not, those who received mental health services were more likely to be older adults, more likely to be insured, and more likely to be white. However, they were less likely to be Black, less likely to be males, and less likely to be Hispanic. When we looked at comorbidities and injury parameters, those who received mental health services were more likely to suffer from a pre-injury psychiatric comorbidity, more likely to test positive for drugs on admission, and had higher injury severity and more penetrating injuries. This diagram illustrates the mechanism of injury of the analyzed patients. The most common mechanism demonstrated in red is cut stab at 65%, followed by firearm injuries represented by the orange 17%, and then blunt mechanisms at 15%. Blunt mechanisms were defined as fall from a great height, lying in front of a moving object such as a train or a vehicle, or intentional motor vehicle collisions. We stratified patients according to age groups and looked at the mechanisms of injury, and we found that older adults, defined as more than 60 years, were the most likely groups to attempt suicide using a firearm. Similarly, we stratified patients by race groups, and we found that white populations were the most likely population to attempt suicide using a firearm. This table demonstrates the results of our multivariate regression analysis looking at the independent predictors of receiving mental health services following a suicide attempt. After adjusting for confounders, we found that middle-aged adults, young adults, and male gender were all less likely to receive mental health services following an attempt. When we looked at racial, ethnic, and socioeconomic factors, we found that Black race, American Indian race, Hispanic ethnicity, and uninsured patients were also less likely to receive mental health services following their attempt. In summary, the incidence of suicide attempts in all adult patients presenting to trauma centers is 1.5%. Only 56% of survivors of violent suicide attempts received mental health services during their index admission or on discharge. And the results of our multivariate regression analysis showed that racial, ethnic minorities, male gender, being uninsured, and younger age were all associated with lower odds of receiving mental health services. In conclusion, significant gender, racial, ethnic, and socioeconomic disparities exist in the nationwide management of survivors of suicide attempts. And there's a desperate need for improved access for these services, particularly among minority populations. And it is important to assess whether these disparities are related to patients, individual providers, system-related factors, or some combination of the mentioned. Finally, targeted firearm suicide prevention, screening interventions should focus on high-risk populations such as white patients and older adults, as these were the most likely patients to attempt suicide using firearms. I'd like to thank my mentor, Dr. Bilal Joseph, in the Division of Trauma at the University of Arizona for this opportunity. Thank you.
Thank you. This paper is open for discussion. Dr. Ring.
Events of 2020 and 2021 revealed that healthcare in the U.S. is grappling with social issues in an unprecedented way. Issues of access to healthcare, insurance coverage, and quality of life outcomes and risks continue to shape America's belief in healthcare equity. I congratulate the investigators, Dr. Joseph et al., for this timely study that begins to look at the social underpinnings of healthcare in the U.S. trauma centers and factors that every surgeon should consider in delivery of quality surgical care to our most severely injured suicide patients. Your results in the study was interesting, but not surprising, consistent with my own anecdotal experience as a trauma surgeon. Although being Hispanic, Black, or uninsured resulted in worse access was consistent with my impression of common social determinants of health, I was surprised by your result that males, being an often privileged group, also did worse. So my questions are these. Number one, why do you think males were not favored to get better mental health care when most of the time they're a privileged class in most social arenas? In other words, what barriers cause males to have less access to mental health care? Two, what are the next steps in research to expand our current study and patch the limitations of your work? And number three, as a trauma surgeon myself, what practical advice can you give me and others like me out there about what we can do to address the underlying causes for disparity in mental health care for our trauma patients? Again, I thank the Western Surgical Association for the opportunity to discuss this paper and appreciate the authors for adequate time to review and reflect on this timely and important issue about healthcare access and outcome.
Thank you, Dr. Wong. Any other questions, please?
Hi, Jordan Weinberg, Phoenix, Arizona. Very nice presentation. Enjoyed that. I was wondering if you're able to look at any systems related issues. I was thinking about rural versus urban in terms of access to psychiatric care or even specific regions of the country. Thanks.
Jason Smith, University of Louisville. Hey, great talk, a great presentation. I think you outlined that we are number one, terrible about connecting folks with suicidality and suicidal attempts with mental health services. And I think that's also a big takeaway point from what you've discovered. One of the questions I had is looking at your exclusion criteria. Did you disproportionately exclude one group or another based off the fact that patients who may or may not have survived may have been firearm injuries as opposed to cutting or blunt injuries? And did that affect, or what did that group look like as far as would that have affected the outcome of this talk? Did you create these disparities by your exclusion criteria? Otherwise, great talk, great presentation.
Thank you. Dr. Ledgerwood?
Ann Ledgerwood, Detroit. I enjoyed your presentation. One of my heroes, Dr. Tom Shires, looked at suicide attempts and found out that a good share of these people had seen a medical care provider within the previous 30 days. I guess my question to you is, who should admit this patient who tries to commit suicide? Is that the trauma service, or do we refer them to someone else, hoping psychiatry would take care of them, which they don't? And what are we supposed to do when this patient comes in? Admit to the trauma service, or hopefully psychiatry will take care of them?
And I think follow up on that is, did you have any data about the patients that did not get mental health services after discharge? Is there any longitudinal tracking to say, well, they were more likely then to try again? So Dr. Joseph will close the discussion. Thank you.
Thank you all for your comments. Start with the last question. We don't have longitudinal data from TQIP. It's a great thing. We're actually starting to look at this within our own institution's data set and then following them through our own thing. Dr. Wang, thank you for your discussion. Your first question on the social determinants of health and why male were not favored in this area. That's a great question. I don't know. I think that, when you look at suicide and type of suicide and attempts of suicide and type of weapon or whatever you want to call it used to attempt suicide, we know that males more often use more aggressive, and that maybe gets them access to trauma centers, but that doesn't necessarily, I think 20% of our patients end up dying. So maybe that group is kind of what Dr. Smith was talking about, that the ones who died because they were excluded kind of changed the results a little bit. Next steps in research. Again, I think this is a signal from a national, I think we as trauma surgeons need to do better. Mental health services is very difficult. There's not a lot of resources. I think that we're looking at our own institutional data now, and then hopefully can go from there to better understand why some of these disparities do exist. As far as advice, I think the other thing is oftentimes at trauma centers, it's, it's just so busy. We're just moving, and Dr. Ledgerwood's insightful comments about, who's admitting them, maybe more protocolized type care and requirements for our patients, where it's not, you can't just assume or guess at the bedside whether this patient does or does not, or psych tells you I can't come see this patient for 3 days and within 48 hours you're discharging. Maybe we need to have a little bit better checklists or triaging type criteria to decide who gets put into that. And then the other side of that is follow-up. How often are we following up with these patients? If they're not injured, they've got a suicide attempt from a trauma mechanism, and then they're not injured, do our clinics see them? Do we see them again after they're gone? Oftentimes we just send them off into this world of, psych, and we don't really get any follow-up on that. Jordan, to your point about rural versus urban and regional disparities, TQIP, you have to ask special access to that. They don't like to get facility keys, but we've tried numerous times to get facility keys to help us understand those things, and it's a continuous battle. Dr. Smith, to your questions about exclusion criteria leading to overall bias, I don't think it's, I think in the group that died, maybe there's a little could lead to a little bias in the data, but overall, if you look at the number of patients, the fact that only 56% got some sort of service, and that includes a consultation or a discharge to a psych facility, we actually looked a little bit closer at the group that died to see, and majority of those were the firearm injuries, as we stated. But again, I'm not sure that I think with 20,000 patients, that bias exists there. And then Dr. Ledgerwood, again, I think that these patients should be admitted to the trauma service. We admit them at our institution to the trauma service with a psych consultation. We just don't have enough psych resources at our facility. But I think once we discharge them or sign off of them and they go somewhere, we no longer follow up. And maybe that's where we could make a bigger impact on this subgroup, because it is part of our responsibility. Thank you very much.
Thank you. The next paper is presented by Dr. Jeffrey Santos of the University of California, Irvine Medical Center on development and validation of a renal replacement after trauma scoring tool.
Good afternoon. My name is Jeff Santos. I'm a general surgery resident at University of California, Irvine. I'd like to start by thanking the Western Surgical Association for the honor to share our paper with you, titled The Development and Validation of a Renal Replacement After Trauma or RAT Scoring Tool. We have no financial disclosures. Renal function is tied to many vital physiologic functions in the human, namely fluid status, regulation of blood pressure, acid-base chemistry, and filtration of toxins, metabolic products, and waste products. Renal failure is not compatible with life, and for patients with insufficient renal function, renal replacement therapy is life-preserving. This can come in the form of frank dialysis or a continuous form of veno-venous hemofiltration for those unstable to undergo a standard approach for dialysis. The demand for renal replacement therapy is massive. About 618 million people worldwide and 560,000 people in the United States are on some form of dialysis. And this incidence is rising each year. While the baseline demand for renal replacement therapy is already overwhelming, the COVID-19 pandemic further stressed the medical system and made challenges for acquiring these resources for patients in need, especially in a time of such limited resource availability. Trauma patients are unique. They have an increased risk of acute kidney injury, upwards of 67%. Admittedly, a small portion, about 0.5% of patients require post-traumatic renal replacement therapy, but it's been shown that timely initiation of renal replacement therapy does improve mortality outcomes. Thus, the somewhat unpredictable nature of trauma patients does pose a challenge for the resource allocation of an already stressed system of renal replacement therapy delivery. This can affect the care for all patients requiring renal replacement therapy. In contrast to trauma patients, those with medical indications of renal replacement therapy, such as may be at risk to may be risk stratified with already current and validated score or risk scoring tools available. Unfortunately, these are all used for patients with stage 3 and 4 chronic kidney disease, and thus are not designed for trauma patients who presented with a normal renal function and then rapidly developed acute renal failure in the setting of multiple traumas or multiple injuries. Therefore, this study aimed to develop and validate a renal replacement after trauma scoring tool to identify trauma patients who will require renal replacement therapy within the index hospitalization. The scoring tool was developed as a retrospective study using the Trauma Quality Improvement or TQIP database. We used a derivation data set from the 2017 to 2018 data set and a validation set using the 2019 data. We included trauma patients who were 18 years of age or older, and we excluded patients with chronic kidney disease transfers from outside centers and patients who died in the emergency department. We collected data from their demographics, comorbidities, details of their injuries, operations based on ICD codes, complications, and whether they required renal replacement therapy, whether that's hemodialysis or continuous veno-venous hemofiltration. We split the derivation data set into two groups of patients that did not require renal replacement therapy and those that did require renal replacement therapy. We compared these two groups with univariate analysis, and any variable with a p-value less than 0.2 was included in stepwise multivariate logistic regression models to identify independent risk factors for renal replacement therapy. We created multiple iterations using weighted averages and odds ratios for each variable. We simplified this scoring tool to an integer based for clinical ease of use. And we checked each iteration using area under the ROC curves to verify accuracy after each modification. Lastly, we validated our scoring tool using area under the curves for the derivation TQIP dataset versus the TQIP 2019 validation data set. If the area under the ROCs were similar or the same, this would validate our study or our scoring tool. The derivation TQIP database, the 2017-2018 database, captured over 1 million trauma patients. 603 required renal replacement therapy. Now, this is not an exhaustive list of our univariate analysis, but it does highlight some key findings, namely patients who required renal replacement therapy were older, male, they had multiple medical comorbidities, required mechanical ventilation, had injuries to the extremities and acute kidney injury, required blood products in the first 4 hours, surgery on the respiratory system, and ICU admission at higher rates compared to those who did not require renal replacement therapy. We constructed the RAT scoring tool by including 8 independent risk factors for renal replacement therapy, including male sex, ICU admission, intubation, history of cirrhosis, diabetes, hypertension, and congestive heart failure, the requirement of blood products in the first 4 hours, the requirement of surgery on the respiratory system in the first 24 hours, lower extremity fractures, and traumatic injury. Our scoring tool ranges from 0 to 8, is integer based. And we saw that the risk of renal replacement therapy steadily rised from 1% to 3.3% and 10.3% at scores of 5, 7, and 8 respectively. The scoring tool has an area under the ROC of 0.88, which signifies a very good prediction capability. The validation data set encompassed nearly 700,000 patients. And as seen by the two area under the ROC curves, they're both 0.88 and identical, which again signifies a very good prediction tool. Using a 3-step methodology, we were able to derive and validate an easy-to-use integer-based RAT scoring tool with very good predictive ability to assess the needs for post-traumatic renal replacement therapy. There are several limitations to our study. One is it's a retrospective database study. So with that carries all the typical limitations such as missing data, misclassification, and lack of data granularity. TQIP does not report some variables that may be predictors of renal replacement therapy, namely baseline creatinine, urine output, CPK levels, mean arterial pressure, nephrotoxic meds, among many, many others. And most importantly, the limitation of its current clinical use in its current form. A RAT score maximum is 8 with a prediction of 10.3 risk of post-traumatic renal replacement therapy. Although this is a 200-fold increase from the cited incidence of renal replacement therapy. In conclusion, the RAT scoring tool is an easy to use with very good post-traumatic renal replacement therapy predictive capabilities. With acknowledgement of its limitations, we believe that this tool is a starting point to build upon for future studies to improve the scoring tool with inclusion of laboratory data and other potential predictors of acute renal failure in trauma patients. This scoring tool has the potential to provide invaluable information for renal replacement therapy allocation, especially in times of limited resources, such as during a pandemic. Thank you, and we'd be happy to answer any questions.
Very nicely presented paper will be discussed by Dr. Weinberg.
I'd like to thank the association and the program committee for the opportunity to discuss this paper. And I also want to thank Dr. Santos for providing me a well-written manuscript well ahead of the meeting. Thank you. So in this study, the group from UC Irvine developed a predictive score for the development of the need for renal replacement among trauma patients. They both derived and validated their scoring tool with the Trauma Quality Improvement Program database. I reviewed the study design with my colleagues with expertise in such statistical analysis, and I can attest to the high analytical quality of this work. The RAT score predicts the probability of a patient requiring renal replacement therapy in stepwise fashion, whereby a maximum score of 8 portends a roughly 10% risk for needing RRT. So I can see the utility for this score to identify a cohort of trauma patients at higher risk for needing RRT for the purpose of ongoing research or quality improvement, but I'm not totally convinced that this is a useful tool yet for clinical practice, such as the resource allocation for planning for RRT as the authors advocate. So with this in mind, I have the following questions for the authors. The author suggests that most of the variables in the RAT score are available shortly after patient presentation. But to my knowledge, there is no timestamp on the need for mechanical ventilation in the TQIP database. So it is possible that some of these patients developed renal failure either before or at the same time as they developed respiratory failure and went on the vent. For example, a patient who developed sepsis late in their hospital stay. The same likely goes for ICU admission. Did the authors account for the possibility of this type of temporal bias in the study? It's also notable that among the 603 patients that received RRT, only 50% of these patients were noted to have the complication of acute kidney injury in the database. So how do you explain the need for RRT in the other half of patients who don't have acute kidney injury recorded as a complication? And lastly, for a patient with the highest RAT score of 8, there's still about a 90% chance that this patient will not need renal replacement therapy. I think this is a result of having so many patients in the study base with almost zero risk of requiring renal replacement therapy. So why not narrow the study-based cohort, perhaps to patients with a certain cutoff for injury severity score, for example, in order to increase the overall risk for renal replacement therapy across the study population and maybe make this score more clinically applicable. Again, I congratulate the authors on an excellent manuscript and presentation, and I look forward to your responses to my questions.
Thank you for your comments. Any other questions? Well, I have one. As far as, are any of the risk factors, because I didn't think I saw one, is something that you can mitigate, so that you say, well, I can reduce the risk by intervening in one of these factors. So, and based on that, so the discussion will be virtual by Dr. Namias from also from UC Irvine. Thank you.
Thank you. Are you able to hear me?
Yes.
All right, wonderful. My apologies for not being able to be there in person. I can assure you that I would much rather be there than on service here. But yeah, in terms of these questions, Dr. Weinberg raises some very important questions, and really, I think all of them are spot on. In terms of the first one that he brings up about temporal bias, that is indeed a limitation of using TQIP with it. Patients could have gone into renal failure before they went into respiratory failure in terms of the mechanical ventilation data point, and then also in terms of the ICU admission data point. So those two data points are ones that could have happened later. That's something that we hope to address in the future with prospective study of this to be able to better ascertain this. In terms of the second question, which is about the incidence of acute kidney injury, we wanted to be intellectually honest and show that in TQIP, only half of these patients had an acute kidney injury based on what was recorded in TQIP. And I think that kind of drives home to the granularity of the data, and the actual perfection of people inputting it is not perfect. That said, you can get an ICD code for acute renal failure. And so we're going to be running that data to see if really the other half were categorized as acute renal failure and not as just an acute kidney injury, even though they should have been categorized as both. The third question about the study population is an important one. And when we first decided to do this, we had tossed around whether or not to narrow it down to maybe just an ICU population, which is something that we still could do. But we felt that it would be better at first to use a generalized population to see, because some of these patients who are younger may go on to have renal failure. And so we wouldn't want to exclude those patients for this initial study. We feel that this is more an exploratory study to see variables that would be helpful. And then the next steps will be to do a prospective, or at least a retrospective multi-center study, where we can get some of the more granular data points like Dr. Santos alluded to, such as their baseline creatinine, their initial urine output, those types of factors, CPK, et cetera. And so we'll hope to do that. And then we will hope that this will be improved further, because we also agree with Dr. Weinberg, this is not ready for clinical use right now. Although it's 200 times more predictive of the general incidence of acute renal failure or needing RRT, still at 10%, it would not be clinically useful to allocate resources. And then finally, in terms of the last question about, are any of these risk factors things that you could mitigate against? So the short answer would be probably not in terms of it. Some of them, such as blood product transfusion or going on the mechanical ventilator or needing an ICU admission, maybe you could mitigate in some ways, but not fully. So I think that would be something that would also be a downside to this, is that it may be more applicable just for resource allocation as opposed to intervention to prevent the complication of going into renal failure.
Thank you very much. Appreciate it. Thank you. Okay, the next paper is also from the University of California, Irvine. Dr. Ruhi Williams and colleagues will be presenting on the outcomes of acute cholecystitis during the COVID pandemic.
Good afternoon. My name is Parisa Ruhi Williams. I'm a general surgery resident at UCI, and I'd like to thank the Western Surgical Association for this opportunity to present our research entitled Impact of COVID-19 Pandemic on Management and Outcomes of Acute Cholecystitis at U.S. Academic Centers. Here are our disclosures. So acute calculus cholecystitis, as we all know, is a very common surgical disease. According to the Tokyo guidelines, the diagnostic criteria for acute cholecystitis are listed as on the slide. So local signs of inflammation, such as right upper quadrant tenderness, systemic signs of inflammation, such as fever, and imaging findings as well that are characteristic of acute cholecystitis. Both the World Society of Emergency Surgery and the Tokyo guidelines agree that early laparoscopic cholecystectomy is the gold standard intervention for cholecystitis. However, patients who are critically ill can be temporized with a percutaneous cholecystostomy tube drainage. And open cholecystectomy usually remains as a bailout procedure. In this recent systematic review published regarding the acute cholecystitis management during the pandemic, the authors found that there was a tendency for antibiotics or percutaneous cholecystostomy tube placement when compared to pre-pandemic. During the beginning of the pandemic, the non-COVID-19 admissions at US hospitals declined by more than 20% from baseline, likely secondary to fear of contracting the virus and lockdown policies. In this study out of our institution, it was shown that there was a precipitous drop in case volume for cholecystectomy at the beginning of the pandemic. There was a recovery, but not quite back to baseline 3 months into the pandemic. And you can see that with that dark line. For this study, we hypothesized that there could be a delay in presentation of acute cholecystitis during the pandemic, leading to more advanced disease, requiring altered intervention and worse outcomes. We aim to compare changes in characteristics, type of intervention, and outcomes of patients presenting with acute calculus cholecystitis who underwent intervention at academic US centers 15 months before the pandemic and the first 15 months of the pandemic. Our study design was a retrospective database study using the Vizient clinical database and 2 time periods. There was the pre-pandemic time period, which was October 2018 to December of 2019, and the pandemic time period from March 2020 to May 2021. We included adults with diagnosis of acute calculus cholecystitis with inpatient admission who underwent one of the following interventions. We excluded choledocholithiasis, cholangitis, perforated or acalculous cholecystitis, or chronic cholecystitis. We use the following ICD-10 diagnosis codes in our methodology. For diagnosis, we use calculus of gallbladder with acute cholecystitis. For procedural codes, for laparoscopic cholecystectomy, we use excision or resection of gallbladder, percutaneous endoscopic approach. For the open approach, open cholecystectomy, we use excision or resection of gallbladder, open approach. And for percutaneous cholecystostomy tube drainage, we use drainage of gallbladder, percutaneous approach. Our primary outcome for the study was the type of intervention that was performed. We also analyzed in-hospital mortality, length of hospitalization, and direct cost. We did follow-up analyses for outcomes based on type of intervention that was performed, and we also looked at patients with both acute calculus cholecystitis and concomitant COVID-19 diagnosis. You can see here our demographics for the pre-pandemic and pandemic groups. Of note, there was a slight reduction in the number of females, white race, and the younger age group in the pandemic group. With regard to our primary outcome, which was type of intervention performed, we noted that there was a decrease in the rate of laparoscopic cholecystectomy from 73% to 69.8% during the pandemic. There was also an increase in percutaneous cholecystostomy tube placement from 18% to 21.5%. For our secondary outcomes, we noted that in-hospital mortality for all interventions increased during the pandemic from 2.3% to 3.1%. The mean length of stay also increased from 5.9 days to 6.5 days, and the direct cost went up as well during the pandemic from $12,500 to $14,600. This was a subset analysis based on the type of intervention for in-hospital mortality. In-hospital mortality remained low for laparoscopic cholecystectomy. However, for patients who underwent open cholecystectomy or percutaneous cholecystostomy tube placement during the pandemic, there was an increase in hospital mortality. Namely, the percutaneous cholecystostomy tube cohort during the pandemic had a mortality of as much as 11%. This was a subset analysis for the length of stay for type of intervention performed. The length of stay for laparoscopic cholecystectomy remained low in less than 4 days. For open cholecystectomy remained around 10 days, but for percutaneous cholecystostomy tube placement, that was significantly higher, 13 and 14 days, with a significant difference during the pandemic. Hospital costs across the board were higher for all 3 types of interventions during the pandemic, as seen here on this slide. We then wanted to look at patients who had concomitant COVID-19 diagnoses as well as acute cholecystitis. So we evaluated this for the pandemic group and noted about 3% of the patients had both diagnoses in the pandemic group. Of those patients who had both diagnoses, the percutaneous cholecystostomy tube remained the #1 intervention at 58%. As mentioned, the type of intervention for most patients in both the pre-pandemic and pandemic group was laparoscopic cholecystectomy. However, if you look at the red bars, those are the patients with concomitant COVID-19 diagnoses, and the percutaneous cholecystostomy tube was by far the highest intervention at 58%. We also looked at in-hospital mortality of those patients with concomitant COVID-19 diagnoses. For laparoscopic cholecystectomy patients, the mortality remained low. For any patient with both diagnoses who underwent an open cholecystectomy or a percutaneous cholecystostomy tube placement, the mortality was as high as 30%. Our study has several limitations. Those are inherent to a retrospective study, such as missing data, misclassification, coding errors, and selection bias. We were unfortunately unable to determine the timing of the intervention related to the initial onset of symptoms or from the date of admission. And we note that a single patient could have had multiple interventions during one admission, but we could not delineate that from the database. The Vizient clinical database lacks patient-level data. The diagnoses are based off of clinical documentation and not pathologic analysis. And as this was an inpatient database, we do not have data on complications or death occurring after discharge. Vizient also includes only academic centers and their affiliates, so our study findings may not be applicable to the community setting. In summary, we found that the rate of laparoscopic cholecystectomy decreased overall during the pandemic, while the rate of percutaneous cholecystostomy tubes increased during the early pandemic for acute calculus cholecystitis management. There were worsened outcomes for patients presenting during the pandemic with associated higher in-hospital mortality, higher length of stay, and higher direct cost. Specifically, those patients that had both COVID-19 and acute calculus cholecystitis, the mortality in hospital for percutaneous cholecystostomy tube placement was as high as 30%. Within the context of the COVID-19 pandemic, there was a distinct change in the interventional management and worsened outcomes for patients presenting with acute calculus cholecystitis. Thank you again, and our senior author will take questions.
Very elegantly presented. Thank you. Dr. Hoag from UC Davis, would you?
Member and guests of the association, I would like to thank the association for the opportunity to discuss this paper from the University of California at Irvine Medical Center regarding the impact of COVID-19 pandemic on the management of acute cholecystitis. Basically, the author have the hypothesis that there is a delay in seeking medical attention for acute cholecystitis during the pandemic, leading to a more advanced pathology and presentation, and consequently change in intervention and with overall worse outcome. I have 3 questions for the author. First, the author observed that laparoscopic cholecystectomy has no difference in in-hospital mortality and length of stay, but a higher cost. That observation that clinical outcome of laparoscopic cholecystectomy was comparable in both periods is reassuring to me. But did the patient truly have acute cholecystitis, or just a mixture of acute cholecystitis and severe biliary colic as often the case in most practice? Do we have data to confirm pathologic analysis to confirm the acute cholecystitis, as well as other data such as perioperative complication? With regard to the higher cost for these cases, do you think it's due to the complication or restriction associated with COVID-19? Second, open cholecystectomy has a higher in-hospital mortality but similar length of stay, whereas percutaneous cholecystostomy has the worst outcome in all three measures. You had mentioned that it's obviously it has something to do with COVID. Did this open cholecystectomy was a conversion during attempted laparoscopic cholecystectomy, or the decision to perform an open cholecystectomy was made preoperatively? And if so, what was the indication? Similarly, the indication for percutaneous cholecystectomy, having severe medical comorbidity prohibitive for operative intervention, or because of the ongoing infection, or last, you didn't mention it, but we have a restriction of availability of the OR, which it make the physician tend to go to percutaneous. And then lastly, you imply that there may be a delay in presentation leading to worse outcome. Intuitively, we all think so. But do you have data regarding the onset of symptom and the timing that the patient present at the ED that will strengthen your paper? And then lastly, we all worry about during the pandemic about the longer length of stay, but does it have anything to do with the surgical pathology, or is it actually related to the complication associated with COVID-19, as well as the restriction on resource during those times? Again, thank you very much for the privilege of the floor.
Thank you. It's open for questions. And Dr. Joseph?
Great work. My question is on transfers. You know, our institution after COVID basically stopped taking, you go on code purple all the time and we wouldn't have transfers. So I wonder, and we've seen a huge decline in our EGS because now patients are going to other institutions that were able to maintain that. I just wonder if you have any data on that, if you could comment.
Hi, Rachel Colcutt from Sacramento. Great presentation. There's the COVID Surge Collaborative, which is an international collaborative that's looked at this and some upcoming results that'll come from the Omicron time period about whether or not mortality and complication rates associated with emergency general surgery conditions are actually different, and they're about to release their results. In that context, we know that putting a PERC chole tube in someone has plenty of data that shows us that it's got some negative effects. But the piece that's missing here is the comparison. If those patients had undergone lap chole while infected with COVID, we know that the mortality rates, at least in the initial portion, exceeded 10%, which is far different than normal. Some of the studies reporting up to 30%. So I think we're missing an important comparison here, that it's in that context of those patients who are actually infected, a PERC chole tube may have actually been beneficial, even though it has an overall higher complication rate.
Thank you.
Doug Schur from St. Louis. Just add on to that, you even showed in your data that the mortality of lap chole, you said it was still low, but it's still 4 times what it was if you had COVID. So as people come in with COVID, how are we going to deal with that? Second thing is you're missing a group. There is a group of people with acute cholecystitis that do not need a PERC chole tube and get better with antibiotics over a couple of days. That's what we used to do for a lot of people that didn't get PERC chole tubes. And if that happened more because either they came in later or we didn't want to operate on them because of other reasons, you're missing that group and how they did. And it is a huge chunk of acute cholecystitis. So how do you factor for that?
Thank you. Diaz?
Jose Diaz, University of Maryland. I do think that that is an important factor that you're missing. At the beginning of the pandemic in March 2020, the American College of Surgeons actually came out with recommendations about what to do with this patient population. And one of the recommendations was not to operate on these patients. And if you had to do an operation on somebody who was really sick, to do it open, because we didn't know whether or not aerosolization of the virus could infect everybody in the room. or to put in a percutaneous strain in everybody and wait until we knew what to do with the patients with positive COVID. I was hoping that maybe you could go back and look at your data, time it out based on when that initial recommendation came out. And as we began to learn about this disease process over time, those with, without, and whether or not that changed actual surgical management. Very nice presentation. Thank you.
I have one last quick question, but the data around acalculous cholecystitis suggests a lot of patients have percutaneous tubes, don't need a ultimately need cholecystectomy. But how many patients in the database had both, had a subsequent cholecystectomy? So they would have coded as a percutaneous tube and later a cholecystectomy, open or laparoscopic. So there may be some insight on the outcomes. Thank you. Dr. Nguyen will close.
I want to thank Dr. Ho for reading our manuscript and certainly providing very insightful question. And I'm glad there's so many questions related to this presentation. And I'll try to answer some of these succinctly because there's so many of them. I'll start out with Dr. Ho question. The first one being the open cholecystectomy group. Are these conversion to open, or is it decision to start as open? I would say these day and age, majority are conversion. So most of us, if we're going to take these patients in the operating room, we're going to put the laparoscope in. No matter how complex it is, a lot of time we can deal with it, including laparoscopic subtotal cholecystectomy when for severe adhesion, etc. So the only time I would think if to start out with open cholecystectomy would be someone with advanced cirrhosis where you worry about bleeding, or a perforated cholecystitis. The next question regarding the indication for percutaneous cholecystostomy. The key indication are being critically ill. I would say that would be the key indication. And that include acalculous cholecystitis, because the majority of that time is related to that fact, not necessarily because of COVID-19. You can't have COVID-19 and you're critically ill and you intubated, sure, percutaneous cholecystostomy. If you have COVID-19, you're sitting on the floor, you have right upper quadrant, and you have acute cholecystitis, we still take those patients to the operating room and do a lap chole. Were these operations truly done for acute cholecystitis, or is it biliary colic? Based on the Vizient database, this is all based on clinical documentation within the medical records. You have to state acute cholecystitis in the medical record. So if biliary colic was initially stated in the medical record, and then you went to the operating room and says, oh my goodness, that gallbladder looks acute inflamed, the pathology demonstrate acute inflammation, then you change that diagnosis in the clinical medical record as acute cholecystitis, and then it will be documented. So we believe that our cohort here represent acute cholecystitis cohort. The next question behind the cost associated with that's higher during the pandemic. That's the overall cost is going to be higher during the pandemic. A lot of that is related to the precautionary measure that we use to prevent COVID-19 transmission, the use of PPE. Also, there's staffing shortages right now, including, it's a little bit better now, but during the initial early pandemic here, we're short in staffing, and we rely on nursing, which cost was actually double that of the cost prior to the pandemic. There was one question regarding to the onset of symptom. Unfortunately, we don't have any data with regarding to when the initial symptoms started, but our hypothesis was that there was a delay in management because the patient delay coming into the ED. We don't have any data regard to that, but I can say that there are many articles that has document delay in presentation of many other disease process to the ED because of the COVID pandemic. So I think we are correct in terms of saying that there is a delay in terms of seeking medical care for acute cholecystitis. Doctor, there was a question related to the lap chole, and in the presence of COVID-19, the mortality is about 4-fold higher
but it's still relatively safe. It's about 1.6% mortality. Normal mortality for lap chole for acute cholecystitis is about 0.3%. So yes, there is higher, but for the patient who are critically ill with COVID-19 that's intubated, et cetera, these are the patient that has excessively high mortality. Almost 1/3 of the patient die from the COVID, from that disease. Let's see here. I think I kind of touched on most of the question, unless I specifically missed something.
Thank you very much.
Thank you.
Jack. And the last paper of the session is going to be presented by Dr. Park on emission creatinine clearance may predict the enoxaparin dose, and present on behalf of their colleagues at Cedars-Sinai Medical Center. Thank you.
Thank you. Good afternoon. My name is Dr. Gregory Park. I'm a resident at Cedars-Sinai. I would like to thank the Western Surgical Association for the privilege of this podium. Thank you, Dr. Paul, for discussing this paper with us. I have no related disclosures. So when everyone here is aware of the risk of VTE in trauma, this is secondary to a physiologic response to trauma, along with the morbidity related to specific illnesses and injuries. For example, TBI patients and those with long bone fractures tend to have prolonged periods of immobilization, which lead to increased rates of venous thromboembolism. Prevention of VTE is a priority in trauma care. Many will be familiar with this landmark paper by Geertz et al. That established enoxaparin is superior to heparin in prevention of DVT in trauma patients. Notably, with this study, they were able to start enoxaparin within 36 hours of injury, which many will appreciate is difficult even today in practice. New guidelines were recently released by Western Trauma, which encouraged earlier, higher, and uninterrupted doses of enoxaparin. The algorithm indicates most patients should be started on enoxaparin 40 milligrams Q12 with adjustments based on anti-TENA levels. In 2021, the Committee on Trauma published their own guidelines with similar recommendations. They also recommend 40 milligrams twice daily for most patients, with a further recommendation of weight-based dosing for patients with a BMI greater than 30. Weight-based dosing can be effective in achieving goal anti-TENA levels. This study from Bernstein out of San Diego highlights how a weight-based dosing program of 0.5 or 0.6 milligrams per kilogram will be sufficient for greater than 50% of patients. However, a significant percentage of patients will be under or overdosed with this strategy, as you can see here. Previous studies established that the rate of VTE is lower when the enoxaparin dose is guided by anti-TENA levels. This study from our group established that 84% of patients required a dose of 40 milligrams twice daily or more to reach their goal anti-TENA levels. Another study from our group was the first to demonstrate a reduction in pulmonary embolism when trauma patients, if possible, were started on enoxaparin 40 milligrams Q12 with adjustments based on trough anti-TENA levels. So this presents a new challenge. Can we determine the enoxaparin dose required to reach goal anti-TENA levels without drawing blood? Weight-based dosing is one possibility, although 2 studies out of Cedars established that weight does not adequately predict high or low doses of enoxaparin. We established that creatinine clearance might be a better predictor compared to weight. Therefore, you have to be aware of obese patients with low creatinine clearance, as they may require a lower dose of enoxaparin than would be predicted by their weight. Similarly, a thin patient with a high creatinine clearance might require a higher dose of enoxaparin than predicted by their weight. So our objective was to determine if creatinine clearance predicts the goal enoxaparin dose. We hypothesized that creatinine clearance can predict the goal enoxaparin dose better than a weight-based dosing strategy. So in our study, we included adult trauma patients who received prophylactic enoxaparin and reached their goal anti-TENA levels within the study period. We excluded patients who were under the age of 18 years, if they were admitted for less than 48 hours, if they were not started enoxaparin during their admission, or they did not reach their goal anti-TENA level prior to discharge. Our institutional protocol titrates enoxaparin based on the trough anti-TENA levels drawn after 3 uninterrupted doses and the dose is then increased or decreased by 10 milligrams every 12 hours to the titrate to the goal range of 0.1 to 0.2 IUs per milliliter. Initiation of DVT prophylaxis is ultimately at the discretion of the trauma team, and per protocol, enoxaparin is held in select situations such as TBI or active bleeding. Data collection included patient demographics, patient characteristics, and lab values. Creatinine clearance was calculated based on the Cockcroft-Gault equation, which is shown here. So we reviewed the EMR and found 3,949 patients who were admitted between April 2017 and May 2019 and older than age of 18 years, including only the adult trauma patients who reached their goal anti-10A levels. We excluded patients for the following reasons. About 1,700 patients were excluded for admission less than 48 hours. About 1,800 patients were excluded because they were not started on enoxaparin or no anti-10A level was drawn prior to their discharge. 22 patients were excluded for heparin, DVT prophylaxis, or enoxaparin once daily dosing compared to the twice daily dosing. 89 patients were excluded for not reaching their goal anti-10A level during admission. So after applying inclusion and exclusion criteria, we ended up with 269 patients who reached their goal anti-10A trough level. Patient characteristics were grouped according to their final enoxaparin dose. That is the enoxaparin dose required to reach the goal trough anti-10A level. This is represented at the top of the table here, and patients are grouped into 20, 30, 40, 50, and 60 milligram twice daily dosing cohorts. We will divide the table for easier viewing. Average age was significantly different across all groups. Older patients were more likely to require lower doses of enoxaparin compared to younger patients. Male sex was similar across all groups. Mean weight and creatinine clearance increased with increasing doses of enoxaparin. Unexpectedly, BMI did not increase with increasing enoxaparin dose. Injury severity was similar across all groups. Hospital length of stay and ICU length of stay were significantly different across all groups, and enoxaparin requirements increased with increasing length of stay. So the mean creatinine clearance, as represented by the blue line, increased with increasing doses of enoxaparin, with a Pearson's correlation coefficient of 0.465. Weight on admission, represented by the orange line, also increased with increasing doses of enoxaparin, but to a lesser degree, Pearson's correlation of 0.299. This is an important slide as our data indicates specific creatinine clearances would dictate the goal enoxaparin dose required for that patient. For example, a creatinine clearance of 70 milliliters per minute would indicate an enoxaparin dose of 20 milligrams twice daily. Again, a creatinine clearance of 90 milliliters per minute would then indicate an enoxaparin dose of 30 milligrams twice daily. Starting dose of 60 milligrams twice daily could not be supported by our data, as only 5 patients out of the 269 required 60 milligrams twice daily. So once again, we found that both creatinine clearance and weight do correlate with increasing doses of enoxaparin, but creatinine clearance demonstrated a stronger correlation. BMI was again similar across all groups, suggesting BMI is not predictive of enoxaparin dose requirements. We concluded that enoxaparin dosing is dependent more so on renal excretion, as evidenced by the strong correlation with creatinine clearance. Further research would be needed to validate this as a dosing strategy. Ultimately, our goal is to expedite prophylactic dosing of enoxaparin and limit the time a patient is subprophylactic. We would also like to reduce the number of anti-10A levels drawn by better predicting the initial dose of enoxaparin. We therefore concluded that creatinine clearance can be predictive of the goal enoxaparin dose better than a weight-based dosing strategy. Our results again indicate a creatinine clearance of 70, 90, 110, or 130 milliliters per minute would require enoxaparin doses of 20, 30, 40, and 50 milligrams twice daily, respectively. Thank you for your attention.
Thank you, Dr. Park. Very nice job. Okay, this paper will be discussed by Dr. Paul.
Hi, good afternoon. I'd like to thank Dr. Park and his colleagues for providing a copy of their manuscript well in advance and for an excellently presented paper. Also like to thank the program committee for allowing me to review this paper. And as I'm the last discussant before lunch, I will try to keep my comments brief. The First question I actually have is about your patient population. So this is a data set from a few years ago, and with all the exclusion, the study population is only 7% of the patients, trauma patients seen during that time frame. And beyond the patients who were only admitted for less than 48 hours, the vast majority of the exclusions were for patients who either didn't get Lovenox or didn't have 10A levels. So could you please clarify whether it was the no Lovenox or the no 10A levels that excluded those patients? And then that leaves us with a small group of patients to actually study. So 85% of your patients in your study ultimately received 30 or 40 milligrams of enoxaparin BID. The extreme doses of 20 and 60% were in fewer than 5% patients, and some of those were single digit numbers. My question is, would using a more recent study group or patient population from say 2020 to 2021 actually lead to more patients included in the study to get us some better information about what's happening with those higher and low dose patients? And then also, could you just comment on whether all your patients who are admitted and are started on enoxaparin get anti-10A levels in 2022? The other question I have for you is about what creatinine level should you use to calculate the Cock-Golf equation? For most patients, the admission creatinine probably represents their baseline creatinine, but severely injured patients, especially those in hemorrhagic shock, often present with an elevated creatinine 2 or 3 times higher than what their baseline would be. And you only see a return to baseline after they've been resuscitated or been in the ICU for a couple of days. So which creatinine should we use for this? And then lastly, I'd like to hear about how your group is using this data currently. The mean creatinine clearance values for each dose appear to be discrete, and that's what you presented on your last slide. But the standard deviations of the creatinine clearance values are very broad. There's broad overlap between doses. So if you look at the standard deviations, if you have a patient with a creatinine clearance of 90, they would actually fall under the standard deviations for 20, 30, and 40 milligrams BID. So how do you make that determination on an individual patient? All in all, this is a great paper from your group continuing to educate us on the proper use of enoxaparin, and definitely showing us that a one-size-fits-all dose is not appropriate for all patients. But I definitely think you need a larger patient group to really refine the use of creatinine clearance. Congratulations on your work, and thank you for providing an excellent manuscript for review.
Thank you, Dr. Paul. Any other questions? Okay, barring that, Dr. Lay, you close the discussion.
Thank you, Dr. Demeure and Dr. Paul, for your insightful comments. Always appreciated. I think you actually reviewed one of our previous VT prophylaxis papers, and Dr. Dillon pointed that out to me, continuing the run here. So as mentioned, the dosing of chemoprophylaxis has changed over the last 5 years. We're doing better, higher doses, earlier uninterrupted doses. As mentioned, most patients require 40 or more. And this is not just in trauma. This is in bariatrics, colorectal, gyn-onc. We're seeing an improved dosing, and that's led to a decrease in DVT, and we're seeing a decrease in PE. Our patients are having improved outcomes. And it's related to this better understanding that it's not a one-size-fits-all. Here it's showed in 1996 that 30Q12, but that's not the correct answer in today's world. So we're now trying to focus on whether weight or creatinine clearance is preferable. And I think that's the real focus of this, that creatinine clearance is preferable, and maybe that initial dose will be more in line with what you would expect because you have a better predictor of what it should be. So per your questions, I think I got 5 of them. So you're correct that we only saw about 7% of the total reach the goal anti-10A levels. That does point out a hole in our database, but it also points out these are the patients that actually were able to get a measured goal within the target range. A much larger percent of patients were likely within the goal range. We just didn't get an anti-10A level measured. I think it also underlines the importance of providing that first dose in the important range. If you have a patient who's only there for 3 days, they're not going to get a trough level measured, but if you start them on 40 or 50 or whatever the creatinine clearance plus other things are, then you're going to get that patient goal range without having an anti-10A level. So I do agree that we need to add to our total ends. The initial review of this data led to a data set that was then augmented by Dr. Park, and we'll keep trying to add to that. We're also looking at TBI in particular, orthopedics in particular. I think both sets of those colleagues could do better with dosing. And if we have this data based on the simple creatinine clearance, it would make for an easier initial dose that's verified. So the first creatinine clearance level, so that was the first drawn level. And there's certainly challenges related to that. I would say that there are going to be variations in the creatinine clearance based on that initial creatinine level changing. And I think it points out to you have to kind of look at the creatinine clearance and you have to measure the anti-10A levels, especially on these long-term players. If you have a patient in-house for 2, 3, 4 weeks, you're going to have to perhaps measure another anti-10A level and increase or decrease that dose. And keep in mind, this is only for patients who have been admitted to the hospital. When you discharge, don't discharge on these higher doses of enoxaparin. So all patients that are institution get a 10A level. It's before the 4th dose. That does make our total numbers with a confirmed 10A level much smaller. And you asked actually, how do we dose? I always do eyeball the creatinine clearance because it's going to happen that I have this obese patient, 300-400 pounds, and their initial guided dose per pharmacy could be as high as 60, but their creatinine clearance is low. And I get real cautious in that situations. And similarly, you have the rail thin trauma patients and they have a creatinine clearance of 200 and their weight is sort of 30. And so we really try to get that patient up to at least 40 or 50 or 60. But more specifically, we do an age-based dosing. So those who are older than 65, we do start them at 30. TBI and spinal cord injury related to the potential complications, we start at 30. Renal failure and a creatinine clearance below 30, we start those patients on heparin TID. And we do actually look at the creatinine clearance to help us with guidance. And this is in conjunction with our pharmacy colleagues who do a great job at Cedars helping us. Thank you for your time.
I want to remind everyone that everyone's welcome to stay for the lunch symposium. The topic is proper use of legal entities for lawsuit protection and tax reduction, something you all need. Thank you.